Good afternoon, everybody. My name is Mila Orlovsky. I'm a clinical data scientist in Zebra Medical Vision. And I'm going to present a work that was done in our team. And Noah Dagan from Clalit already mentioned previously. I'm going to present a work that was done where we developed a big data tool to conduct medical imaging AI inference, and we use this in emulated T-score in spine CT. So before we get into the project, I wanted to talk about the global crisis that the radiology sphere is facing. We have annually growth in the number of scans performed in the medical imaging. We have billions of people are in need for radiology services. However, the amount of available radiologists is not growing that vastly. It means that today the radiologists are facing much more overload in their work. They're working on more scans, more slices per scan, and eventually there is a crisis between the supply and demand in this area. So Zebra's medical vision is on a mission to mitigate this problem. So what we do is train computers to automatically read and diagnose medical imaging. And we have a vast, sorry, this is not responding, okay. We have a broad coverage of products today in the market. We have products in triaging medical imaging. So we have in chest X-ray, we have pneumothoraxes. You can stop by our poster later and see the use case of pneumothorax. Another triage product is head CT, so we identify intracranial hemorrhages in head CT. In oncology, in mammography, we identify breast cancers. We also have solutions in the cardiovascular systems. And the other use case is bone health. And today we are going to talk about the bone density. So let's start with numbers. Almost 9 million people are suffering today from fractures that are caused from osteoporosis. 20% of them are suffering from hip fractures, and up to 48 million people worldwide are at risk to develop osteoporotic fracture. This prevalence has increased in the recent 30 years, and it is more frequent in elderly patients and more frequent in females, and it has very vast, very large annual cost for the economy. So we know it's a big problem, and again, Noah has already mentioned the motivation for this, but if we identified it early, we can take the patients and put them in a program, in a prophylactic treatment and intervention, and we can reduce this risk. So what we did is take the DEXA screening, which was again mentioned that this scan is used to identify the bone density, and it is today underutilized. People up to 20% of the population are going through this routine, and this is not enough. So what we did is taking the DEXA score, which measures the the DEXA scan, which measures the T-score, and it divides the T-score to 3 groups, either the normal bone density, osteopenia, or osteoporosis. What we did is using routine CT and we are using CT scan from chest or abdomen, which people are coming to do for a routine checkup. So they, for example, could come for a liver checkup, and we're taking their CT scan. We are transforming from axial view, which is a 3D view, to sagittal view, which is a 2D view. You see it in the middle image. And then we classify the vertebrae, and we calculate the T-score. So we're basically simulating the T-scores from routinely acquired CTs. We are doing it by deep neural networks, and we're having very great results. Now I want to take this project where you saw already the interventions that Clalit is doing with this, I want to take it more into the development process. So our development process in Zebra starts with, obviously, research. We're getting the problem, we're investigating, we're POCing, we're assessing risks. Afterwards, we're training the algorithm. We're using supervised learning, we're tagging all the examples that are going into the training, and we're trying to feed the algorithm with as much as representative data as we can. Afterwards, we're validating internally the algorithm. It means we're feeding them with another set of data, we tune the parameters, and we finalize the algorithm. In the final stages of testing, we are testing the algorithm with the data that he's not seen before, the held out data, and we're reporting final results. All these processes are needed of ground truth data. It means that we need to tag every study of the city. And I'm going to concentrate on this part of the process, the validation process. This process has its own challenges. One of the major challenges specifically in clinical data and medical imaging data is the establishment of the ground truth. So in CT spine, we don't have the T-score results, so we somehow need taggers to tag it. And this operation is not an easy one, because the taggers need to annotate the vertebrae, and this is a very challenging use case, and the operation itself is time-consuming and costly. So this results our test set not being very large, and we want to think of another approach to this. We obviously do this step because we have products in the market and we go through the step, but we want to think of something else. So another approach we took is validating without ground truth. What does it mean? We run inference at scale, and we try to compare our results to worldwide literature. So we took 2 studies. One of the studies was done on 99 million DEXA reports in the United States over a course of 5 years. Another study we had from 2005 had 30,000 scans over a course of 16 years. And we ran the inference at scale, and we compared the results with the literature to estimate the sizes and trends. So basically what we got from this process was a very large proxy test set. It just takes some time. Okay. How we actually did it, we developed internally a distributed Dockerized pipeline. It is running over Kubernetes, and it is able to run multiple instances parallelly. So we were able to run inference on over 300,000 chest and abdomen scans on a matter of hours. So it was a big time thing. So after we ran the results, again, this is taking some time to respond. First thing we did was compare the demographic cohorts to see if they are comparable, and we saw that they are actually similar cohorts. We did see that our cohort had a lower proportion of females, but our patients were significantly older than the right article cohort. We also looked at the distribution of our T-score, and we saw that there was a nice Gaussian distribution to it. So we could move on and compare similar subgroups within the data. So you see in the graph, in the x-axis, you see the risk groups, normal bone density, osteopenia, and osteoporosis, and on the y-axis, you see the percentage of each subgroup within the population. So we do see a high correlation between Zebra cohort and the right cohort. The right is the article of the 99 million patients. And we see for all the risk groups a very high correlation. We do see that in the osteoporosis group, we were a little bit more strict. We predicted more osteoporosis than they did. We also compared the cohorts in terms of age groups. So we also here saw that the cohorts behaved very similarly. we see the trend of the normal bone density population is decreasing over age groups, and the difference were not significant. This is the second study that we compared our results to. We took you see in the graph, according to age groups and the average T-score. So we calculated for each age group and gender, we calculated the average T-score, and we also saw that the trends are very similar from our results to Lunel 2005 results. And we saw that trend that is known that females' gradient is higher for females than males. So what have we learned from this process? Sorry. What have we learned from this process? We learned that a step in the process before we do the final test set, when we validate internally the data, we can do this process where we experiment and analyze inference at scale. We don't use ground truth, we just run inference and we test we analyze the results. The thing is that if we use only computational effort, it is something that is less time consuming, and we can compare the results with worldwide literature. The fact that this pipeline was working parallelly reduced the time effort for this process, and we were also we're happy to know that our results were in the right direction, and we could move on and test the data in the final steps. But I do want to mention that this step, again, this is internal development step. This is not the final test set that was reported to the FDA and the final product. Thank you very much.